So I'm so happy to have Dr. Susan Rogers here today, president of the Physicians for National Health Program. She is recently retired from Stroger Hospital in Cook County and continues as a volunteer attending hospitalist and internist there. While she was at Stroger Hospital, she was co-director of medical student programs for the Department of Medicine and received numerous teaching awards from medical students and residents. She is an active assistant professor of medicine at Rush University, also in the Chicago area, where she continues to be an active member of the Committee of Admissions. So while she's getting set, I just wanted to remind you all that on May 31st, we will have an event with Reverend Rodney Sadler and Imam John Ederer and Rabbi Judy Schindler, who will be speaking with us about reaching out into faith communities, which is a really important way to reach out to diverse communities. People that don't look exactly like the people who are in the room here. A lot of us may not be active in our own local congregations, but we need to learn how to speak to people where they are. So Susan, thank you.
Okay, well, here's my first slide. So let's get started. What I wanted to start with was just to tell you a little bit about how I got to this point. You know, just my journey to becoming a physician. And I think that I probably had it better than, easier than a lot of other folks, but I grew up in Chicago in a neighborhood, Hyde Park. I don't know if many of you have heard of that, but it's right, it's close to the University of Chicago, but it's one of the very few totally integrated neighborhoods in the city. And when I was growing up, there was a park right behind where our house was, and you know, all the kids would play in this park. And so I grew up not knowing there was ever anything all of anything. I didn't know there was anything all black. I didn't know there was anything all white. And you see these things on TV and it doesn't really register with a child. But so I grew up thinking that this was normal. This was the way that life was supposed to be. And I was also a camp counselor at a camp that when I was in high school. And that camp it was a YMCA camp. Most of the campers came from Chicago and from surrounding suburbs, but that camp was also pretty well integrated. So I was actually quite naive about how the world was. Although my mother was very, she was a social activist. And I remember when Martin Luther King came to Chicago to protest against the segregation that was going on in Chicago, that he described as just as bad as what was going on in Selma, Alabama. And at the time, the school superintendent decided not to improve any schools in the Black neighborhoods that were being overwhelmed because there were too many children for the school. And so what he was doing was bringing in these vans. We used to call them Willis wagons because his last name was Willis, but they were mobile classrooms. And that's actually when I went to high school, they decided finally to build a new high school. And I took my freshman biology class in a Willis wagon in a mobile classroom because the school wasn't big enough. And actually that was when my first experience with science at that level. And that's when I decided I was going to be a biology major. I wasn't sure I was going to be a physician at that time. But that was when, you know, things started becoming a little bit more obvious about what was going on in this country. And when I was in high school, that was when afros came about and I had my wire rim glasses and I was an Angela Davis wannabe. And that was the whole culture of this integrated neighborhood that I grew up in. And then I decided there was a guy that went to school with me who I had grown up with, who was a year ahead of me, who was going to the school in Colorado where they took one class at a time. And I said, oh, this would be great. And you took 9 classes at a time, 9 classes a year. So I applied and I got in, and so I went there, and talk about a culture shock. It was a small, all-white liberal arts college in Colorado Springs. And the only thing that Colorado Springs had was Fort Carson and churches. It was in the middle of the Bible Belt, and it was very military. I had no idea what this, back then, nobody visited colleges. It wasn't, you just went wherever. And it was quite a culture shock to see all these white students. I had never been in a class where I was the only Black person. And these students had never been in a class with a Black person either. And it was quite a culture shock. And it was also, there were a lot of very wealthy students there. Now, I did not grow up poor, but we were not wealthy. And it was awful. It was quite a culture shock, quite an awakening. And at the time, then I decided I'm not going to be a doctor because that's what they're doing. I'm not going to be like that. That was the Angela Davis in me. I was anti all of that. And so I left and I went to an HBCU. I said, I can't deal with this Black school, this white school. And I didn't stay at the HBCU. I decided to come home, and I finished my last year at home. But what I realized was that I finally did want to become a doctor, and I wanted to become a doctor to take care of Black people. And so one of the things that I realized too was when students at this school in Colorado would ask me about why Black people aren't doing this and why they're not doing that, and slavery ended 100 years ago, why are they still like that? And I didn't have a good answer. I didn't know how to answer that. And I realized I wasn't taught any of this history either. All of this that I'm going to tell you today, I learned on my own. I didn't learn it. I didn't learn it in high school. I didn't learn it in college. And so when I went to medical school, I was at the University of Illinois. We had a very large class. There were over 200 students in the class, and there were about 20, I think there were 28 Black students in the class, Black and Hispanic students in the class. And most of the first couple of years, you know, you read your books. Well, on my first clerkship that I took, and there was a time we finished the curriculum, and then there was some time that you could either take off and study for the boards part one, they called it, or you could go ahead and take a clerkship. And I had done pretty well in school. So I said, I'm just going to go ahead and do the clerkship, and I'll have more time for electives and do this. So my first clerkship was OB-GYN, and I'll never forget, I was doing the gynae rotation, and we had a small conference with the residents, and the two other students were on the class on the clerkship. And the attending, who was an older white man, asked me a question, something about menopause. And so I answered the question. Now, I tell you, I was nervous the whole time. It was my first clerkship. I mean, you know, we didn't have white coats before that clerkship. So being a student in the hospital was brand new. So he asked me this question, and I told him what I thought was a reasonable answer. She had menopause symptoms. What would I do? And I said, well, you know, we could try to give her hormones. And that was when all women got hormones for menopause, not like today. And his response to me was, that's what's wrong with Black doctors. You do things without know what's going on. And I didn't know, I didn't say anything, but that's what he told me. This attending was also the attending who wrote my evaluation for the clerkship, who wrote that Susan works very hard, but she doesn't know very much, but she should pass anyway. And I knew that was totally wrong. And I went to the dean, and the dean didn't help me. And that was my first experience of really being subjected to this overt racism. And to tell me I didn't know anything, which I knew was wrong. And I say that to say that we as physicians need to call out racism in the hospital when we see it. And we need to protect students who are subjected to this. We can't have the same code of silence that police do and just not say anything. And it's very difficult for students because they need that evaluation. They need that letter when they apply to residency. So they're not in a position to necessarily criticize an attending physician. But I think that that's our role and we have to do that. And that story has I've never forgotten that experience. And I will say that that was probably one of the worst I had in medical school, but it wasn't the only one. And I know it's still going on because that same culture is still in everywhere else in this country. So that behavior, those thoughts, they are still there. And so we won't eliminate it from healthcare unless we call it out when we see it. And I can't stress the importance, especially as attendings, that we do that. Along in other areas, other aspects of our life, we need to call it out. But I think it's very important in healthcare too. So now we can get into, it's racism, not race. And that's why we have the inequities that we see here. So as physicians, words we use are very important, and the definition of words and what they mean is so important. When we use the word disparities, that gets used a lot, but all it means is that there's differences. It doesn't tell you anything as to the reason why. It doesn't tell you how bad they are. They just say that they're a difference. Whereas the word inequities implies something unjust and unfair about it, that it shouldn't be there. The WHO, the World Health Organization, uses the term inequities. The US insists on using disparities, but I think that we should always use inequities because these aren't just differences. These are created, and I will get into why it's created. So another definition I think that we should be comfortable with is, what is systemic racism? And what systemic racism is, it's a system. It is built. It's in the institutions. It's in our policies. And they produce these disparate outcomes. They produce these inequities. And they're not dependent on racists to make them function. They don't need racist people. If you read about how Black people cannot get a mortgage, it's not because the mortgage broker was racist, it's because the system is racist, and it doesn't allow Blacks the same forgiveness for things, and it requires things from them that it doesn't from others. And so they often don't get mortgages. And I'll get into some of the causes here, reasons why that happens. But they're there and they work on autopilot. They're not dependent on people to make them function. So there's been a lot of talk about the biological differences in inequities, but it really isn't biological. And when you think about what is race, I mean, what makes me Black? It makes me Black is that along in my family roots, someone was a slave. And so that the term Black is what defined who could be a slave and who could own a slave. And that one drop rule, if there is one drop of Black blood, you are Black. It has nothing to do with genetics. The Genome Project showed that there is no genetic differences between races that can account for anything. So say it's just a social description. It's a social description of who people are. It does not imply anything that you can say this group has that. It's no different than saying all tall people are this and all short people are that. So there were studies during slavery to show that craniotomy sizes were smaller, but they really weren't. Vital capacity, and this is one of the things that we still use today. And it's still thought that Black people have lung function that is about 10 to 15% smaller than whites. And so this was their reason for having to continue them to work as slaves, because that hard work would improve their lung function. But this is extended into what we use today when we order pulmonary function tests. It's important in how COVID patients are determined what kind of care they should get, whether you should get oxygen. So the fact that these are used, and this is the same thing with the GFR. The GFR, the glomerular filtration rate, that determines how your kidney function is. And it's been said that Blacks have more muscle mass. So, and since creatinine comes from muscle, their GFR is higher even with normal kidney function. So what does this do? It overestimates the kidney function in people of color. And so they don't get on the transplant list when they should. So this is a racist policy that is not based on any evidence, but it keeps people from getting the transplants that they should get. So these are the things that are systemic. They don't require a racist nephrologist. The system is there. Pain control, it's been felt that Black people can withstand more pain. So patients with sickle cell often don't get treated adequately. Badil, and there have been studies shown with long bone fractures that everybody knows are painful, that Blacks and Latinx patients do not get adequately treated for those injuries. Badil was a drug that came out and they did a study. This guy did the study because he thought he could make more money if he showed that it worked better on Black patients. And so he did this and he got it approved by the FDA. And the thing about this is this study only had Black people in it, and it showed that the Black patients who got the drug did better than those that didn't. And so the drug was then approved only for Black people. But when we look at all the guidelines that we use in medicine, they're not based on diverse study groups, who's in these studies. But when they're done with mostly white people in the studies, those results are then extrapolated to apply to everyone. But when you have a study with only Black patients, it's not extrapolated to apply to everybody. It's only to apply to Black people. And so Badil, it actually has been taken off the market because it didn't sell. But the FDA got a lot of criticism for that because they approved this drug for that purpose. We've talked about, you've heard about algorithms, and these algorithms are tainted, and they really are not sensitive to racial differences. And some these algorithms even have race in there, which is totally inappropriate. It's not a scientific variable that should be included any more than your hair is long or you're over 5 feet tall, you know? So these algorithms are really not appropriate because they're tainted by the way they're written, and they discourage, they are not fair to a lot of minorities because of the way these algorithms are. And I don't know if you've heard of this term, excited delirium. And that's a term that's come about, it's been here for several years, but what it is it's the American Association of Psychiatry, or the APA, I'm not sure what the eponym is, but they don't really use this because they say it can't be defined. But what it is that delirium, as we know, is an acute change in mental status, unlike dementia, which is a long-term change. But it's an acute change in mental status, and it gets treated. If you think that people have this, they treat it with ketamine, which is a respiratory depressant, which can cause serious consequences when done in the field. So what has happened is that police have grabbed on to this diagnosis. It's inappropriately and almost only used with Blacks that they stop. And if they end up acting what they think is inappropriate or change in mental status, then they diagnose them. They're not doctors, but they say they had excited delirium, and then they may call paramedics who give them ketamine. And there have been deaths for this. And so the American Psychiatric Society is against using this term because it doesn't have a definition. They can't define it, and let alone diagnose it in the field. However, it's used by police to justify their violence against Black people that they stop. So this is something that, and one of the things that's happened, just recently, I think in California or somewhere out west, but there have been emergency room doctors that work with police departments to train them how to use this diagnosis. But there's been some medical societies that have said physicians can't do that. And there have actually been emergency room doctors who have been fired because they would not stop working with the police with this. But this is how this continues. And so even though we've gone a long way from craniotomy sizes found in slavery, we still find another way to find a justification to get away with what people want to do. So this is a book, The Philadelphia Negro, that W.B. Du Bois wrote back in 1899. And what it was is he was looking for an answer as to why Black people in Philadelphia were dying of tuberculosis. And what he found is that it was the social determinants of health. He found that it was poor sanitation, it was poor nutrition, it was overcrowding in these neighborhoods. And what he found is what we call nowadays the social determinants of health. And how he did this study, actually public health still uses the systems that he used to come up with this, to find this result. Now, there's still, it was interesting because I just read something about the American Hospital Insurance Program, which is some organization that supports private insurance and wants it. And they had a sentence in this thing that I read about recent data has shown us that social determinants of health may affect healthcare. Now, he found this out in 1899, and they're saying recent data shows. So that's a private insurance company, so they will believe whatever they want to believe. But clearly, this data has been out there, and we all know. So what are some of the policies that have come about? Well, the Homestead Acts were, there were two groups. There was one, the original Homestead Act, that started back while slavery was still before the end of the Civil War, and it lasted until the 1930s. And what this was it allowed white people to go west and deed land, and it was given to them for just a filing fee. And if you look at what happened from just this experience, about 10% of all the land in the US was given to white homesteaders for little more than a filing fee. Blacks couldn't go out there, especially not in the 1860s, because it was illegal for slaves to own property. So they were not allowed to do this. It was only for whites. And what they found was that all of this was given to, all this land was given away to whites. And what they have calculated is that the number of adult descendants from this original Homestead Act to people living in the year 2000 is estimated to be over 40 million people. 40 million white people have benefited from this original Homestead Act that started in the 1860s. And so what this is saying is that there are people today who can trace their legacy of wealth back to this Homestead Act that started in the 1860s. And it's no different that Black people can trace their poverty back to being not able to access this policy. So if white people can take advantage of this, and that's part of the reason why they have wealth today, the lack of access to these things is the reason why many people are poor today. There's many more of these instances that I'll get into. And there was a Homestead Act that came up in 1866, but it was not really available to many Blacks because after the Civil War, many of them got into sharecropper agreements, and it was a criminal offense if you got out of a contract within a year, and it only lasted until a year later. So there's very few, there's only about 4,000, I think, African-American slaves that were able to take advantage of it. So I show you these pictures. One of the things that happened after Reconstruction ended is that white plantation owners we're in a quandary. How are we who's gonna work the fields? Who's gonna plant our cotton, pick our cotton? Who's gonna do this and that? So they came up with contract leasing. And what they did is that they came up with a thing, I don't know if you've heard of the black codes, but they were just rules that only applied to Black people, like walking too fast on the sidewalk or not getting out of the way quick enough for a white person walking. If you owed a debt, and a white person could say you owed them money, and if you didn't pay it, then that was a reason to go to jail. So what they did was they arrested and put all these Black men in jail. And so they developed what they called contract leasing, and they built prisons at this point. There really weren't any prisons before the end of the Civil War. But now they built prisons, and this is where these Black men who were arrested for these black codes went, and they were then leased out to these farms. They were leased out to coal mines. They helped build the roadways, the roads and all, and the trains, the railroads. And this is how it was built. It was convict leasing. And does anyone know what this picture is on the right? That's a picture of today. So we don't have contract leasing anymore, but we have mass incarceration of Black men through other rules. And so this provides the free labor. There is now, many corporations have factories in prisons, and they pay them pennies for the hour, on the hour for what they work. So they have cheap labor. And this is part of the prison industrial complex, is they have filled these prisons with Black men on drug charges, and that other, white people don't get arrested for. They don't get stopped for. They don't get their car checked for that. And so this is what's happening. So you have the same system back at the end of Reconstruction, and then you just replace it differently so that it's consistent with the culture, with the norm today, at the time of today, but it's the same purpose. So the structure is there, but the mechanism changes so that you get the same result. You still get Black men in prison to do the work. And if you look at what happens in New York City, New York is about 43% white and about 24% Black. But who makes up 94% of the marijuana arrests in New York? It's men of color. And that's who gets sent to jail. So this is a system of providing labor. The Flexner report came out in 1910, and this was done to revamp how medical education was. And in the beginning of, in 1900, there were over 10 Black medical schools. Now, the way medical schools were funded, a lot of the white schools were funded either by philanthropists, white philanthropists, or they were government funded. States gave them money. Black schools didn't have that luxury. There really weren't Black philanthropists at this time. Black people didn't have any money, and the government was not giving any money to fund their schools. So they were paid, students who went there had to pay fees, which many of them didn't have. So Black medical schools were poorly resourced. And so many of them were shut down. And at one point there were 20 something Black medical schools. By the 1900, there were only 10 in 1923, because they changed the curriculum. What they said now is similar to what we have today. You have 2 years of basic science and then 2 more years of clinical curriculum. Black schools couldn't afford to do this because they didn't have the money. So in 1923, there were only 2 Black medical schools left, and those were Howard and Meharry, who are still here today. We now have 2 more Black medical schools. In 1966, Charles Drew Medical School in Los Angeles, and Morehouse in 1975 was developed in Atlanta. But Black schools were never able to provide enough physicians, and Blacks could not get into white schools. So there's always been a lack of minority physicians here. And even if we look today at the Black enrollment in US medical schools. Now, I went to medical school in 1979, and this was in the midst of affirmative action. And affirmative action actually started in the 60s, but it really ramped up in the 70s. And then it was included in the early 70s to also include gender discrimination. So women started getting included in admissions to medical schools in the early 70s. And if you look at the numbers, by the time in the early 1990s, about 40% of medical schools were female. They had gone from very small numbers to now almost 40%. So affirmative action did more for white women than it did for minorities in terms of getting into medical school. And if you look at medical school admissions now, it's about 50-50 men and women. And this is because of affirmative action. Now, affirmative action did help. Would I have gotten in if it wasn't for affirmative action? I don't know. And when you think about where women, were they not accepted because they were unqualified? It wasn't like all of a sudden they were smart enough to get in. They had always been smart enough, just like Black people had always been smart enough to get in, but we weren't admitted. So would I have gotten in? I don't know. I don't know, but I think I was lucky in that I was born at the right time and was able to take advantage of this. And then what was the comment? I forget the Republican congressperson who said it, but when our new Supreme Court justice was presented to be proposed to the Supreme Court, his comment was, oh, so now we have affirmative action here. So there's still this sense that affirmative action enrolled unqualified students, and that's totally untrue. The fact that I'm here today tells you I was qualified. And one of the things that affirmative action did was that it changed the way medical schools and this country looked at what makes a good physician. I barely passed calculus. Do you need to know calculus? And that lack of knowledge, I don't think has affected one single medical decision that I've ever had to make. So it's not that you need a 4.0. You don't have to be exceptional in organic chemistry. There's a lot that's involved in being a good physician. And I think that one of the things affirmative action did was that it brought that out. And that allowed a lot of white students who weren't necessarily 4.0 students either get into medical school. So affirmative action helped everyone. It was not a vehicle to allow unqualified Blacks into medical school. It allowed a lot of other students who didn't go the traditional way into medical school and become doctors. Now, one of the things that happened after the turn of the century too was, especially in the 30s, there was a lot of migration of ex-slaves that left the South and came north because it became so inhospitable up in the South. And so this is, I think this picture is either from Philadelphia or Pittsburgh. I think it's somewhere in Pennsylvania. But here they're talking about the Negro invasion and the block is being ruined. And so segregation was just as pronounced as, in the North as it was in the South. And even when Blacks came up here, because they were segregated, they were only allowed to live in certain places. Those areas were overcrowded. I'll get into that in a second. But so Black neighborhoods were the only place where Blacks could live because they could not live in neighborhoods where white people lived. Now, this is a book, Buried in the Bitter Waters. This came out, I think, in the 70s or 80s. But it talked about, you've heard of the Tulsa massacre, but it talked about these counties and cities where they just destroyed all the Black people who lived there. And they could do that and get away with it. Nobody was ever convicted. No one was, Black people were never compensated for what they lost. And it was just racial cleansing that wiped out Black populations in countries all across the nation. Now, we've all known about the lynchings in the South, but these stories often weren't told. So a lot of people don't know about it. And many of these counties that were cleansed, as they called it, remain all white today. Black people have never gone back. This is just a picture of what happened in Tulsa. This is a town that was like any other prosperous town. They had churches, they had businesses, they had banks, they had schools, they had neighborhoods, everything that makes a good place to live. And because it was Black people, I guess they didn't know their place. They shouldn't have had that. And so they burned it down and destroyed it. And again, no one was ever compensated or punished for this. So now we talk about the New Deal, because when I took history in high school, I mean, this was what saved the country. This was just the best thing ever. But what the New Deal really, one of the things that it didn't do, well, one of the things it did really was continue the structure that maintained segregation. And if we look at Social Security and we look at who was allowed to get Social Security, people who were farmers or domestics were not allowed to receive Social Security. So who were farmers? They were Black men. Who were domestics? They were Black women. So this was purposely made so that most Blacks could not get Social Security. Aid to dependent children was started, and that was started in the 60s. And this was really, it was a program to help white women. And what it did was it provided women who were single mothers, for whatever reason, could have help taking care of their children. And Black women were not allowed to partake of this. And this did not extend to Black women until the 90s. And then it became an entitlement, and they were giving away to people who didn't want to work. Now, white women had gotten this all these years because it was the right thing. It was felt the right thing to do to help them. But to help Black women in the same position, it was giving them something that they didn't deserve. So this lasted until the 90s, until 30 something years, almost 40 years. It was a it was a totally inequitable. This is how these inequities are created. The farm security position, the farms were stolen from ex-slaves who lived in the South. And at the time, the majority of the population in the South were Black. And most of them were farmers. That was what they knew how to do. And with slaves, you could not, it was illegal to learn to read and write. So they just had their land stolen from them. They had no recourse. They could not access attorneys. They couldn't read the paperwork. There was no way for them to deed that land to their family when they died. So it was just stolen from them. And even later in the 80s, when there was a farming breakdown, I forgot the name of what had happened, but the farmers couldn't sell their product enough to compensate them for what it cost them to grow it. And so they got reimbursed by the government. However, Black farmers, out of 16,000 farmers, there were less than 200 Black farmers that got recompensated for this. And then the Wagner Act, which allowed unions to form and to lobby as a group. And this way they got better benefits and all. Black people who worked weren't able to get into the union, so they couldn't avail themselves of it. Again, it's a structure that creates an inequity. One of the biggest things that the New Deal did was it established government secure mortgages. And this was before you got a mortgage however you want it. But this way, the government secured it so that banks knew that if someone defaulted on the loan, that they would get their money back. But because of redlining, which there were maps that showed where Black people lived, and that those district areas were redlined, and they would not approve mortgages within that area. So Black people could not get a mortgage, and there were restricted covenants, and that's what neighborhoods made, which would not allow you to sell to Black people. So Black people were, the only way they could buy a home was through a contract mortgage, which was a predatory loan, that often the circumstances really made it difficult. The taxes were higher than they should have been. And what had happened was that you didn't own your home until you paid the last payment of your mortgage. It's not like now you get equity into your home as you pay on it over the years, and you still get that equity back if you sell it before you bought it. Here, so many people lost their home because they also had to fix it. It was almost like you owned and rented at the same time. You had to fix the roof. So these expenses with this kind of contract mortgage just made so many Black people lose their homes because they couldn't afford it. And this is no different from the subprime mortgages that happened in the 2000s. When Black people applied for a mortgage, they were steered toward these subprime mortgages, even when they had adequate credit to get a regular mortgage. So they were preyed upon. So this is still happening here. And like I say, the mechanism changes, but the structure does not change. And if you look at all the home ownership loans that were established by the FHA, white people received 98% of those loans. And knowing that home ownership is how people get equity and how they accrue wealth, it leaves Black people out. And this is just a map that shows the redlining. So you can see Black people didn't have a lot of places where they could go. They could only live in certain areas. So of course, things got crowded. Those neighborhoods weren't kept up. They didn't have the services. And this is what created ghettos. It wasn't because Black people wanted to live in neighborhoods that had no sanitation, that had poor housing, that had no amenities. This was where they were forced to live. And then if you look at the GI Bill, which came another 10 years later, which was federally funded but state administered, so that the states could decide what they would provide. Again, Black GIs couldn't get home loans, either from banks or from the VA. There were training facilities that were set up for the GIs when they came home to either build on a skill they learned or to learn a new skill. But those facilities were segregated. So Black GIs couldn't take advantage of those. The GI Bill to pay for college. Well, colleges in the South wouldn't admit Blacks. And this is where most Blacks lived, in the South. Most of the HBCUs where Black students could go were filled and overcrowded. Even the Tuskegee Airmen, who were fantastic pilots, still were not able to become commercial airline pilots when this was the industry that was now taking off. They weren't able to avail of that. And even my father, who came back from Europe after the war, still had to go and sit in the back of the bus when he returned home to Georgia. And so what has been created? Segregation has created ghettos because these neighborhoods have never been supported. They were never supported with the mechanisms that allow them to flourish. And so now what has happened is that we have areas of what we call concentrated poverty. And this is where 30% of the neighborhood lives below the federal poverty line. Now, let's keep in mind the federal poverty line doesn't distinguish between poor and not poor. It's just a line that determines what benefits you can get. There's a lot of people who have 2x, 3x, 4x the poverty level who are still living in poverty. But what has happened is that who lives in concentrated poverty now? Well, it's mostly Black people. And if you look at Chicago, where I live, 35% of poor Blacks in Chicago live in areas of concentrated poverty. How many white? What's the percentage white? Less than 5%. Because poor white people can still live wherever they want. Even me, I would not be accepted in any place that I would necessarily want to buy a house. I can't just buy a house wherever I want. Not every neighborhood wants me. That's still today. I don't care if I have $1 million cash to pay for the house. I still can't buy it. I won't be welcome there. So what this has done, poverty is different for Black people than white people. We all hear stories from white people. I was poor and I worked hard and I made it, but they may have lived in a neighborhood that provided them with the structure to help them function, to help them prosper, to help them build. They had better schools, they had grocery stores, they had sanitation, they had better housing. So Black people haven't been able to live in those areas. And even now, you have Black families making $100,000 a year, living in a neighborhood with other people who make only 30,000, because there's limited areas that Black people can live. And so if you look in it, what it happens is that people who grow up here, it becomes very difficult to get out. There's no way to be upwardly mobile because the resources to help you do that are not there. So what has happened is that all the things that neighborhoods should have to flourish, they've not been purposely not been provided in minority communities. And once that happens, it creates its own justification. And once employed, it creates the data and perspectives that can support its continuation. And if you look at a wealthy neighborhood where there's a low crime rate, it's not because there's more police preventing crime. It's because the community has all the assets that it needs to prosper. Whereas in poor communities, rather than provide those assets and structures to allow them to prosper, they put in police. So it perpetuates. I look at, all the carjackings and all the robberies of stores. This is why. It's difficult to get out of here when there's not a structure to support you. None of us got to where we are today by ourselves. None of us. I don't care how hard we worked. And so when you enforce people to live in areas where there is no structure to support them, this is what happens. And so what has happened over the years is that Black families have not been able to really accrue the wealth that they need to be able to prosper. And the wealth gap now is worse than it has been in years. But the wealth gap is more important than an income gap, because a wealth gap gives you a safety net. It gives you access to loans if you have money in the bank. It allows you to help your children, whether they need help with tuition, whether they need help paying rent, or when they need help for anything, you can help them. So a family's wealth isn't an endpoint. It's the starting point for the next generation. Whereas when you have no wealth, every generation starts at square zero, because there's nothing there to help them. So that it's very difficult and then what happens is there's many of my friends are taking care of their parents because their parents weren't able to accrue enough wealth for them to be able to still take care of themselves as they get older and they're no longer to work. So inheritance perpetuates this wealth inequity. And it's really counterproductive against the whole idea that if the equality of opportunity, the opportunities aren't there. Not for everyone. Even when you do make it as a physician, you're still not looked at. I mean, look at the experience I had as a medical student. There's things that's happened even as I've been an attending physician. But I don't know if you've heard the story of Dr. Susan Moore, who was I think in Indianapolis, and she was went to Indiana University. She got sick with COVID. Now, this is a woman who has underlying sarcoid, which we know is going to increase her risk. And she was looked at as a drug seeker because she was complaining of pain. She was not treated as a colleague. She was treated as a complainer, as a drug seeker. She was sent home two times. The third time she came back to the emergency room, she was admitted and died of COVID. Totally unnecessary. Totally unnecessary. And that's the bias. And the thing about bias, I don't know why we use that word, because it's really racism. You wouldn't you wouldn't believe the bias you feel if it wasn't for racism. And I don't like using that word bias because it's sort of racism in disguise. She's just drug seeking. That's not bias. That's a racist thought. And I think that these are the things I think that we have to call out. If you look at these communities at high risk of COVID and high risk of being sick from COVID and dying from COVID, low-income communities where people who have minimum wage jobs with no benefit, the essential workers, this is where they live. Half of those communities have no ICU beds because the way we pay for healthcare, those hospitals can't afford it. And then there's stories about ERs in wealthier communities wouldn't take the patients from these ERs because they knew they wouldn't get paid as well. So these are the structures that create these inequities. And this is just, I know this is a little bit hard to read, but this just shows you that poor communities don't even have pharmacies. So when you make a policy that the two bottom lines, the green is the Black segregated communities and the red are Hispanic segregated communities, they have the fewest number of pharmacies. So when you're told to go to CVS or go to Walgreens, I don't know what the pharmacy chain is where you live, to get your vaccine or to get your COVID test, there isn't one in your neighborhood. And you probably don't have a car to get one, to get there. So this is the structure. And when you build these policies without acknowledging the inequities of the structure, your policies will worsen the inequities. And, you know, when people talk about colorblind policies, they can't be colorblind. Because what a community that has all the resources to help the members of that community thinks all neighborhoods have that and writes the policy, they're missing, because they'll never go in this neighborhood and realize they don't have pharmacy. So there's all of these things here that made COVID worse because the structure didn't accommodate the needs and it worsened the inequities. And if you look at how medical care is funded, this is just a comparison between sickle cell disease and cystic fibrosis. Sickle cell disease affects about 1 in 340 Black children. Cystic fibrosis affects 1 in 2,500 children. Now, who gets the most NIH funding? Who gets the most foundation funding? It's not according to need, clearly. Sickle cell, of all the funding, sickle cell disease gets less than $1,000 per child with sickle cell. I shouldn't say child because there's adults too. Cystic fibrosis gets over $10,000 per child, person with cystic fibrosis. So even the funding, even the NIH, a government institution, isn't equitable in what they do. So this is a structure that perpetuates inequities. And, you know, we don't talk about it. We don't realize it. It's invisible. We don't even think it exists. And it's very, you know, why did poor people get COVID? Well, you know, they smoked, they were obese. I mean, I've heard these comments. And it's a total ignorance of the facts that's going on, but the facts aren't taught, they're hidden. You have to make an extra step to learn this stuff. And if we look at the Affordable Care Act, I mean, half the states, most of the states that didn't expand Medicaid is where most people of working age, most Black people who of working age live, and they didn't expand Medicaid. So how are they supposed to get health care? And if we look at the CARES Act, we look at the CARES Act and the Paycheck Protection Act, the structures were not there to provide the care that minority and poor communities needed. If you look at the Paycheck Protection Act, you had to have a relationship with a bank. Drive through a poor neighborhood and tell me if you can find a Chase ATM or a Bank of America ATM. Those banks aren't there. You can get a payday loan. You can go to a currency exchange, but there's no banks. So all of these structures that are considered normal and necessary for communities, they're not there. So and what this slide shows, the billboard in the back, there back in the 30s, the I don't know what they would call it, but the manufacturing industry was touting, this was after the Depression was over, and the New Deal had invigorated the economy and things were coming back. And so the American dream, we have this American dream and we will, take care of everything. This is the American way. And we're better than anybody. And this is what the American dream was. You have your car and you're married and you have your 2 children and a dog. But as you can see, the American dream didn't apply to everybody. And the Black people standing in front of this billboard were the people flooded out in Louisville who were in line to get help from the Red Cross there. So we've had this misconception, this myth that America is this ideal, that if you work hard, you'll get there. And no matter, and people work hard. You can't tell me a frontline worker does not work hard. They'll never get any kind of dream, whether it's the American dream or whatever. So this country was never made to be equitable, never created to be equitable. And what we see now is the outspokenness of white supremacy, the cancel CRT, critical race theory. I mean, it was never really taught. I wasn't taught that. And I lived in the North in an integrated neighborhood. I had to learn all this on my own. It wasn't taught. So in order to get equity, we have to be honest. And if we keep living in this dream world that the US is all this and all that, and we have the best health care in the world, we don't. Even if you look at the life expectancy of every socioeconomic class in this country and compare it to a comparable socioeconomic class in a European country, each socioeconomic class in the US does worse than the comparable socioeconomic class in Europe. So we're not doing good, even for those who think they're doing well, even for those who can go to the Mayo Clinic and pay cash. Their group is not doing as best as they could be. So it's in everyone's interest if we address this and if we fix this. And I know I've talked too long, but I get very passionate about this. And I think it's so important too that you hear this, because you need to tell your friends what I've told you. And when you argue about why things happen, I will share my slides. I'll send them to you, Betty. And I'll leave the notes there so that you know what each slide is talking about, because I don't know what's going to happen if we don't address this. I really don't. And I have grandchildren now, and I want to make sure that they can grow up and be a physician like their grandparents.
Well, thank you so much, Susan.
I am going to stop sharing, and I'm now back on. Wait a
So
minute.
I really appreciate you bringing this all together for us. I'm wondering if others have questions that they want to ask before I ask some of my questions. Sharon, can you unmute yourself?
Yeah, I worked at NIH and the FDA. I left in 2001. But you're right about Black people. I only know one Black person in the cancer division that I was in. I'm sorry, I didn't realize my voice was a little hoarse. And when I was in the FDA, there was one Black woman. Of course, we had people from other countries. I guess I'm not counting them, but there was only one Black American woman. So you're right, the disparities really haven't changed.
And part of the problem is with segregation. I mean, I don't know how many Black people you all even know, that you come in contact with, that you can call, that you call or whatever, we become so separated that it's easy to believe myths because there's no life experiences other than what you see on the news,
Yeah, true.
to make you think any different.
Yeah, it's true.
Lynn, could you ask your question?
Well, it sort of follows to what was just said. And I was reflecting on my 40 years of nursing. I retired about 11 years ago. And I think in my 40 years, I may have worked with one Black RN. And I remember she was a military nurse and she was excellent. Of course, I worked in New Hampshire, California, Northern California, were the demographics that I worked with. In San Jose, I worked more with Latinos than, and when I worked in a nursery, I never took care of a Black baby. Most of them were up in East Palo Alto, which is a minority community, and they were at Stanford, and I wasn't working at Stanford at that time, but it's your presentation was excellent, and it makes me really angry that it makes it so difficult to change things.
Thank you.
Thank you. So I have a question. Chuck, do you have a question or do you have a comment?
It's more a suggestion of how do we address what Susan has laid out for us, and that is upcoming in Washington, D.C. on June 18th is the Poor People's March. And this is a really, really important opportunity for white people, especially to show their allyship and support, to step back and to march with brown and Black and queer and immigrant people who are desperate for change in this country. And I'll share more information going forward, but maybe Susan, I saw you nod, maybe you have some thoughts on that as well. I'm coupling up with a lot of folks here in Pennsylvania to get buses out of Pittsburgh and Philadelphia into DC. I know a lot of you are out west, but this is a really important opportunity to show our solidarity and to build the bridges, the kind of bridges that helped us succeed with the civil rights movement back in the 1960s. I think we've gotten a long ways from that, and we have to get back to those connections. And that includes faith communities and people who share our values but are not necessarily political, but also social justice campaigns. So I just wonder what your thoughts are on that, Susan. June 18th, I think it's a big event. It's, William Barber, Poor People's Campaign.
Yes. And if you've never heard Reverend Barber speak, it's an experience. He is just so great. He's just a fantastic speaker. I don't know if he's going to be out there in person or not, but I think that if you look back at the civil rights movement, and if you take a look at the pictures, there's a lot of white people in the pictures. They were instrumental in getting all of that done. And if you look at the desegregation of hospitals, you know, white people were involved in that, in getting that done. So, you know, when Johnson desegregated the hospitals with Medicare. So a lot of the workers, it takes everybody. And that commitment is easy if you realize that you will benefit from that. Your children will benefit from that. Your grandchildren will benefit from that. So it's not just an experience for you, but it's something, just like we teach our children things all the time that we think is important for them to know. And I know that when I went out and my mother took my brother and my sister and the three of us marched with Dr. King, I mean, I never thought she was an activist before that, but that just changed my impression of her. And it also made me realize how important that was. And I think that when you do things like that, you send the message, you know, to others who know you, especially those coming up behind you, you know, how important this is, because the things that they're going to need aren't going to be here either if we all don't get it. The inequities are going to widen. And unfortunately, the way the economics in this world is, if you're not a billionaire, you may not be able to have anything. It's a crazy thought. I mean, I don't know how far that can go. But yeah, Chuck, I'm glad you brought that up, because we do have to, you know, that has to be part of what we need to do. Zoom calls are nice, but boots on the ground are better.
Yeah. Thank you. So I have a specific question. So many people do not know about the extent of the country's historical segregation in medical care, or some of the shocking practices based on race, some of which you just have described to us. Often they don't have the time to put forward the effort to learn about these things. And I'm also wondering, so white people may not have had the time, may have not seen the relevance, may dismiss it as not, oh, that racism is done. Look at the Civil Rights Act, and now we've had a Black president, so we're done. We don't need to talk about that anymore. And but it's also, as you said, it's not taught in schools, and you had to learn this on your own. So a lot of Black people aren't aware either of the racial segregation and the misuse of research, that sort of thing. So I'm wondering what suggestions you might have for how to educate people, all people, on these issues and help them become more ready to act on these concerns.
That's a good question. And I think a lot of it will depend upon what you read. I think reading is a good way to learn and to read, you know, read some history. If you, I can send you a list. I can send you, Betty, a list, because I'm kind of blanking on names right now of where to go, and some websites that I think would be useful.
But it's actually not so much the question, like, we have resources, we can look them up, we can find them. I mean, there's books like CAST and
Yeah.
and you'll be sending your slides, we'll have that, we can look at some of the resources you mentioned there. But what I'm wondering more is, like, you're talking to the choir. These are the people who saw the title for your presentation. Now, some of them may have already seen your presentation when you were at Davis, you know, but of those who hadn't already seen this talk and wanted to come, they already had an openness in their mind that, oh, there may be health disparities, or I know there are some, I'm not sure why. I mean, they already had an openness to the topic. How do we open the hearts of more people?
One of it is that you have to be willing to get uncomfortable. And that if you don't want to have hard conversations, you'll never change anyone. And I think that part of being a social activist is getting out of your comfort zone. And you have to bring things up, and you have to be able to talk about things that you know will make people uncomfortable. And you have to be comfortable with that uncomfortableness.
Mhm.
And I think that keeps you going because you know you're doing the right thing. We all do things we know are hard, but they're necessary. And this has put this one on your list of those things that are hard to do, but are necessary. And, you know, it can be with, you know, your neighbor, you know, or whatever. You can, it can be very informal, you know, in a relaxed setting makes it easier to be uncomfortable in, you know. But that's what you have to acknowledge, that there's no easy way to convince people. Now, don't go to a MAGA rally and try to convince people because I mean,
You'll
that's
get
not
killed.
where you're gonna find anybody who wants to, you know, listen to you. But there are, you know, areas, you know, that, you know, even with people who you know may disagree with you, there's still a way to approach them
Thank you.
in certain settings. Not always, but there's a way. And at least get them activated. You may be able to convince them that you need to be active in this too.
Thank you. And now, Bill, can you speak? And then Lynn, if your hand is still just left up as a leftover, could you please put it down? Or if you want to speak, you can speak after Bill. Bill?
Susan, I was wondering, in looking at 1976 and at CalCare and at all the single payer legislation that we have, is there language in any of those policy bills that would be central to beginning to explicitly address these disparities? And do you think that our single payer legislation, our policy model, is a tool to directly address some of these inequities and these horrors?
Well, single payer will not eliminate all the inequities that we see. It's a start because a lot of healthcare depends upon living in a community where you have a grocery store, where it's safe for you to walk, all the social determinants of health. But I think that if we could expand global budgeting so that we can put resources where they're needed, equalize all that so that it becomes fair in all neighborhoods, that's one of the things that we can do. We have to be careful about how it's funded. And I think it's important that the federal government, and I say that now, but who knows who's going to be running the federal government. But if we leave it to states, you know what's going to happen. There's going to be, like, the states that didn't expand Medicaid will not get involved in making sure that a single payer system is functional in their state. One of the things, if we look at what happened with the desegregation of schools in the 1950s, what's happened? They're still segregated. Two reasons why: because communities are still segregated and children go to neighborhood schools. And it's also the way schools are funded, which is inequitable. If they're funded on property taxes and you have a neighborhood where the median price of the home is, you know, $100,000, and then you have another neighborhood where the median price of the home is $750,000, who's going to have the better schools when it's funded by property taxes? So that poor neighborhoods are not going to be funded as well as wealthier neighborhoods if you have a funding based on that. So here is where the structure comes in. It doesn't mean that the school board is racist. They're not getting the money that they need to be equitable. And so those are the things that we need to make sure that we address. But I think that in terms of making sure that single payer can become equitable, we have to make sure that things like that don't happen. And that's why it can't be left to the states, because the states will not prioritize all communities. And we have to be careful even with the federal government, because I don't trust them to always do things right either. I don't care who's in office or who runs the Senate or the House, you know, it still takes activism and oversight to make sure it's done equitably. But I think it has to be federal, because then everybody gets the same. Because if you look at Medicaid, each state has different benefits. And because the money comes from the feds, but the state decides where it goes. Medicare, everybody has the same benefit. And so it's a much easier system to fund and to function. And so we have to do the same with single payer, is make it federal oversight and not leave it to the states, because you see what's happening now with states.
So thank you. Lynn, did you have a question?
Yes, Susan, are you familiar with the movie, The Green Book?
Yes, yes.
Do you want to tell people what that's about? I had no idea when somebody said, you got to see this movie, and the title didn't mean it. And I always go to a movie without knowing anything about it. And it was quite a shock.
That's an interesting question, because I have a story to say about that. But the Green Book was written by a Black man as a resource to Blacks who were driving around the country, and it listed where they could safely go, to sleep, where they could eat, and what places to avoid. And so the Green Book was a story about this book and this man who wrote the book. And my parents told me a story that my father had a sister. I grew up in Chicago, like I said, had a sister who lived in New York, and they decided that they were going to drive to New York. Now, I had a brother who was 2 years older than me. And at that time, I was born in 1953. And at that time, I was a baby. So we were in the car driving to New York, and they had made a reservation at a motel. I assume it was a motel. And they got there and they wouldn't let them stay there, even though they had a reservation. So this is what the Green Book, and this was in the early 50s. And the Green Book was to help avoid those sort of situations, so that you could travel and know where it was safe for you to go and where you could get the things you needed along the way. And it's becoming close to that again. I think that there are areas in this country that I would never stop in. I don't care what kind of car I had, I would never stop.
And you think that that's worse, or that it's more visible now?
I think it's more visible. It's very clear. I mean, you can tell when you're welcomed, and where you're not wanted. And it doesn't matter if you pull out an American Express card to pay for it, they still don't want you there.
Right.
And that makes it real clear. And there's a lot of these towns. There's, I don't know if you've heard the term sundowner towns.
Yeah.
Yeah. And those are towns where if you were Black, don't be in this town when the sun goes down, which meant you could not live there.
Right.
And they weren't just in the South. There were thousands across the country, many in Illinois, where I live. And there's towns in Illinois I wouldn't stay overnight in still.
Thank you. It's an experience that those of us on this call who are white have never
Yeah.
had. Yeah.
You don't think twice about where you can or cannot go.
Well, as women, we do think about that a little bit too, but
Yeah, I mean,
for a
there's
different reason. Yeah. So I'd like Barbara to ask her question, and then Mike can be after we hear Susan's response.
Well, I'm still on Bill Bronston's comment that 1976 does in fact address equity, and it has a section where it makes people accountable toward equity. So that's like a first step that almost every institution that's trying to get rid of its racism starts with, is at least making people accountable for being and for being fair that way. But I've heard Black people say, oh, it just doesn't matter whether, whether it's this white person or that white person that's paying the bill, who cares? But the thing about single payer is that it's not corporate, it's the corporate that we can't control. And when you look at, well, I actually have read, I was bowled away by The Power to Heal, because I was a freedom rider and I did all that stuff, but I had no idea. I had no idea that, I graduated from college in 65. I never knew that Medicare had done what it did.
Mm.
Then when I read the book, The Power to Heal, going into it, they specifically chose the hospitals and they were able to do it, but they mentioned it, but they also did not try the doctors. And then by the end of that period, Johnson apparently was on his way out and they didn't try the doctors, but they very specifically said they were not going to do what they did in education, because education let them do it at all deliberate speed. And they said, forget that. You're just not going to get any money. You're just not going to get the money. You want all these new patients? You can't have them unless you're desegregated. And you can't just change the signs. We've got people going in, and that's where you were talking about all the whites. There were lots of whites doing secret shopping in all of those hospitals where they were trying to say that they were segregating when they weren't. I mean, they were desegregating when they weren't. But the thing about single payer is that it's democratic governance. It's not people in a back room making decisions and saying, how high can we make the price today? So it's not going to solve everything. But in fact, the VA, the military, they do much, much, much better because they have teeth against systemic racism. They can't get rid of racism, but at least they have teeth against systemic racism. So I'm somewhat encouraged when I think of those, except for when I think of DCEs and ACOs. But I'm somewhat encouraged when I think of those because it's that factor. I mean, it's the factor of not having the profit motive in there. And you did mention global budgeting, which is part of the single payer, formula. But anyway, so I think that we really can press for combating success, effectively, if not completely successfully, effectively combating systemic racism with a single payer system. And the other big thing is the medical deserts that we have that are intensifying, right? We have more and more medical deserts for different things. There's no maternity in all these years. There's no emergency care available. There's no this, there's no that. Well, if you wanted to create those, you would just start with a profit first system. If you wanted to make sure that you were only going to have medical services where there's money, that's what you would do. And that's what we have. And that's what we got. Anyway, I don't have a question for you. And I'm sorry I missed your talk tonight, but I've heard you 1,000 times and I love you. So.
Susan, did you want to comment on anything that Barbara just said, or should we ask Mike what his question is?
No, I just have a short comment. I think that one of the problems is that I think even with governmental oversight and making people accountable, I am very concerned about how much of a reality that really is. And I think that the way congresspeople are lobbied and funded, the distinction between private corporations and government has become very, very blurred. I don't even know if there's a difference anymore. And so I'm not sure if the government, if Congress people have the backbone to do what they need to do, because they're more concerned nowadays about getting reelected than doing the right thing.
Yeah, there's a wonderful book called The Politics Machine or something like that, that really talks about where the little power nexus are, that tiny little things. Anyway, I appreciate it, but I do think, I think the VA tells us something.
Well, the VA
Um,
is in the process of getting privatized.
Yeah, I know. So we have to, if we can't stop it, but it's the privatization. It's not the government, it's the privatization.
The government
course,
is letting it get privatized.
I know. And in fact, so what is Medicare doing? They're giving away Medicare
Yes,
to as fast as they can.
yes.
I'm okay. So I don't trust the government that way. But if the government were doing what we're supposed to be doing, it could do it.
So that's another
Anyway,
conversation.
thank you very
we'll
much.
have
Let's
to
send
have
somebody
about
else.
how do you transform our democracy to get money out of politics and have people have access to their Congress people instead of corporations. That's another conversation. Today, I'm going to ask Mike, though, what his question is for you.
Yeah, I just want to reassure Susan that the state-based efforts are not, the goal is not a Medicaid apartheid like we have. It is to get a national program. And the reason we focus on state by state is that's where we can educate best. We have the ear of our state legislators. They listen, and our candidates in particular, they are the people who end up being our federal representatives. So that's just one way in which state-based efforts will get us to a national program. And the other is that people listen when it's about local healthcare. And so we can talk about, all right, until Congress gets its act together, we will do our best to get it at least in one state. And I know our challenges are much greater than Canada had, but it still is a possibility that it could go that way, as did women's rights, marijuana, gay rights, state by state. So please be patient with us. We're not looking for a state apartheid.
Absolutely. I want to second that we're not looking to have failure to expand Medicaid and failure to achieve Medicare for all on some states. And there absolutely is that risk that with anything, if you do, incremental approaches, if you just get that little increment until there's just not enough people worried anymore, then they stop fighting for it, then you could have people left over that never got what those others got. So there's many things we have to be guarding along in our struggle. That's one of them. And another is that as we go along, that you don't stop the struggle. As we see, the VA is starting to get privatized. We're having to fight for Medicare that we have now before we've even tried to do the expansion. So there's a lot. And the other thing is that even if we have Medicare for all and it reduces some of the inequities, there's all of Susan's talk about the inequities related to housing and food deserts and bank deserts and for schools with inadequate funding. All those would still be problems with our healthcare becoming available to everybody. But they've shown that the Congressional Budget Office has shown that we would have so much more money in people's pockets that would be, you could put more money into your schools. I mean, there could be other things that we could do with the funds there. Susan, did you want to make any comments in response to what Mike just said? Or should we go on and ask Mary Uva?
We can go on.
Okay, Mary? Can you unmute yourself there? Thank you.
Hi. Well, first I want to say thank you, Susan. I grew up in a neighborhood, I think similar to where you grew up. And yet I still have so much to learn. And your presentation is amazing. I do have a question, and that is about Medicaid. We talk about state-based systems, and I agree with, you've raised it several times. We have, I think, 90 million people on Medicaid now, and disproportionate numbers are people of color and women and children. And there are a lot of really well-meaning people out there who I would love to have them working with us, fighting for universal healthcare. Instead, they're fighting for Medicaid expansion. And the whole premise of Medicaid is that you have health care if you promise to stay poor. That's basically what Medicaid is. And I know too many people who are gaming the system. They're keeping themselves in poverty. They're controlling their income to make sure that they keep their health care through Medicaid. I'm curious what you think about that and what we can do as organizers and advocates for Medicare for all. How do we tackle this?
Well, the underlying problem with Medicaid is that we are the only country that has a separate healthcare system for poor people. I mean, why is that? Is it because we don't value them? It looks like we don't value them because we don't reimburse for those visits. That's why a lot of doctors don't want to take care of those patients because they don't get reimbursed appropriately. And the fact that it's become managed by private insurance companies is taking even more dollars away from, providing health care with that. So I think Medicaid has to go. Because if we have a single payer, you won't need Medicaid. Why is it that in our system, the poor people are the ones that nobody wants to treat? And that's how we built the system. The way it's built creates this inequity because we're saying it's okay that we don't pay the people who take care of poor people as much. We don't provide for them the same resources. Look at what Medicaid does for people with disabilities. It dooms them to a life of poverty so that they can get the care that they need to take care of their disabilities. Even if they could work part-time, if they make $1 more than whatever the Medicaid maximum is and where they live, they lose their health care benefits and they need that to survive. So it's a system that is not equitable and it's not fair. And Medicaid expansion, I mean, it helped, but it really is sort of like, putting a Band-Aid on a cut that's, needs stitches. The Band-Aid will help, but it's not going to replace the stitches you need.
Yeah.
And so Medicaid shouldn't even be here. We should all be covered by the same thing. That's my view of Medicaid. It's just it devalues the patients that it's supposed to take care of just by the nature of how the system is created and funded.
Yeah, it's such a state by state thing. It's actually a pretty strong program in Vermont. The coverage is actually pretty excellent. But that's apparently, I was surprised to find out how very variable it was as I became more of an activist and found out it was pretty poor in a lot of other places.
Decides, yeah.
Right. So yeah, I do think people frequently are very confused. It seems to me really obvious that if Medicare is changed so that it's expanded to be Medicare for all, then there wouldn't be any Medicaid. And
right.
Yeah, so I don't understand how that isn't more clear to people. But the thing is, right now, the reason we do have Medicaid is because we don't have Medicare for all, and we can't make a federal program cover more people. So the Medicaid is what we do have control over. We don't have control over Medicare. Right. Mary, did you have your hand up because you had another question, follow-up question, or are you done? Okay. Do others have questions, or should I go back to my list of questions that I wanted to check in on? I guess I still, okay, Diane?
I just wanted to comment that in my experience, I sometimes write op-eds into the local paper. People are under the erroneous assumption that Medicare for all will be the current Medicare extrapolated to the general population, and they don't realize that the rules will be totally different. And I think that really works against us because, there's the 20% gap that the federal government doesn't pay that you are responsible for filling and so on and so forth. And that's giving Medicare for all a bad taste in many people's mouth. So we have to be a little bit more upfront about what really is in the Medicare for All bill.
Yeah, well, single payer has in what we present, we improve Medicare for all and we expand the benefits so that it does cover long-term care and nursing home care, which it does not cover now. We would cover dental, we would cover hearing, which only Medicare Advantage covers now. So that's where I think the focus should be, rather than trying to improve Medicare Advantage and these other programs, REACH and the DCEs and all, which involve privatization, which just, is just the train that allows them to steal money from the Medicare Trust Fund. But if we improve Medicare for all, that would replace the need for any of these other programs, and it would be cheaper. And people would get what they wanted. There would be no copays. There would be no, out-of-pocket expenses.
That's true. And my point is that we have to make people aware of that
Yeah.
better than what we are currently doing.
Heather? Heather and then Sharon?
Hey, I just wanted to say, I'm a healthcare organizer here in New Hampshire, and I know Betty. Hi, Betty. And we in New Hampshire also have over 20% of our population on Medicare. We have 20% over 65 population, and then there's even more of that are on Medicare. And oftentimes I find the people that are on Medicare now are possibly maybe afraid of losing something. They have what they have and they don't want that to go away, yet they also don't know what's happening with the ACOs and Medicare Advantage. And I feel like this is a population that could really be our allies here. If we were really organizing with them and educating them on how things are working and how this would be more equitable if we set out to what we were going to do in 1965 and have Medicare cover everyone. So just want to throw that out there because it's something that I keep going back to and thinking about because of our population here. But I know we're not alone. In other states have that high population of elderly folks as well. And I think they should be on our side. But I really appreciate your talk too. Just wanted to say that.
Thank you.
Thank you. Thank you. Now there's somebody else who had their hand up, and I see Diane has her hand up too. Who was the other person who had it? Oh, Sharon, right. Sharon and then Diane. Oh, and I just want to mention that Susan can't stay on for too much longer. So if you can make your question pretty brief, that would be great, so we can hear back from her. And then we could take a 10-minute break, and then we could come back to talk about what are we going to do with this. We can either stay in one group, depending on how many there are, we can break into a couple of breakout rooms, but talk about taking action. But for right now, I really want to take these couple minutes before she needs to leave to hear Susan's responses. So if you have a comment, not a question, save that for later. Let's ask Susan questions when we can get her response now. So Sharon and then Diane.
All right, I have a comment, so I'll wait till
You can
later.
save it. Okay, great. Thank you. And Diane, did you have a question?
Comment.
Okay, and Lynn? You're muted.
Susan, I heard you on with Elizabeth Warren in that meeting. It was great. There's a lot of back and forth in OPS about the ACOs. What is the latest with the ACOs? Is there any hope of us preventing them from going forward?
I have hope, yes, but we will see. We will be, we have been talking with CMMI and CMS, and they are very resistant. They are coming up with new changes to the current, to the current program, things that they say will benefit it and will address inequities. But there's no way that this program will address inequities And there's no way that this program is going to pay their private equity investors and still save money while providing quality care for Medicare patients. I mean, it's
That doesn't
like,
work.
I mean, we can all do math. It's just not there. So they're just, I don't know how, I mean, it just shows you how controlled our members in Congress are by these lobbyists, that they can't see through this. You know, I mean, it's like, I don't know, it's like your children never grow out of being teenagers and they continue that behavior forever and ever. It'll drive you crazy. And, you know, it's got to stop. And I don't know why, and I don't know if it's that there's just a whole new type of person who goes to Congress now than they used to. I don't know. It's quite frightening in a way, but I think that I know that we will be doing a Zoom panel. I will, you know, the details haven't gotten together, but we will be doing a panel on how there's no way that the new REACH program will be able to address inequities, which is what they're trying to say they're going to do. And it's not possible.
And
It's
it's
like,
probably
I'm a
going to be more of a
doctor.
boondoggle.
Yeah, I mean, it's silly. It's just frustrating how they don't see through their arguments and their pleas, but
But Susan, what do you think about a person like Don Berwick? I don't think he's in somebody's pocket, right? Do you think he's in somebody's pocket? And yet he really believes the catechism of value base.
yeah. And he believes that ACOs are the solution. Yeah.
And I don't think, you know, and then when he says it, then Sheldon Whitehouse says it, and then somebody else who's a supporter says it, and so forth.
Yeah.
And yeah, but as you say, if they would only do the math, okay, never mind.
Yes. So
So-
I don't. I can't speak for him, but I know that he supports the ACOs of that. And even though I don't think he's a single payer supporter. He may be, he said it sometimes that he supports single payer, but rather than working for that, he's working to keep the ACOs.
Well, they're incompatible.
Yes. Yeah,
Okay,
exactly.
That's like the people, I'm for single payer, but I can still keep my insurance.
Yeah.
yeah.
I like my silver sneakers. I want to.
I actually went to an older woman's house today, and she had her silver sneakers of subscription. I thought it was a joke, you know.
It's,
Oh,
I
I
mean,
don't actually know this joke. So thank you, Susan, so much for your presentation and for your willingness to stick in here with us for another 45 minutes of questions and
my
comments.
pleasure, because we're all in this together. And all I can say is, and say again, is, you know, we need to call out the racism when we see it and learn to be uncomfortable doing that, because after a while you won't be uncomfortable. It's like anything else. And that's the only way that we can push this and make people see.
So thank you so much